We are assembled here at the seminar on Carcinoma. It is a great honor for me to introduce a speaker for today, Dr. Aswin Kumar, who will be giving us an insight into endometrial cancer and its intricacies. Dr. Aswin Kumar is an adjunct professor of radiation oncology and the registrar at the Regional Cancer Center, Trivandrum. He specializes in gynecological and genitourinary oncology and has more than 40 national and international publications to his credit. He is a passionate teacher. He'll be guiding us today in understanding the principles of managing endometrial cancer as we discuss in clinical. We grateful for taking his precious time to guide us. It is a great pleasure to have you here. Thank you, sir. I would like to request Dr. Aswin to address the audience.
Thank you very much for the invitation. Am I audible? Thank you for the invitation. Thank you, Dr. Sharma, for inviting me for this. I'm not an expert in endometrial cancer, but hopefully I've been looking after patients with endometrium for a very long time, and so that sort of qualifies me to talk about it. And one thing I've learned is we learn by teaching. So this is a long way in educating myself about carcinoma endometrium. Thank you once again for the invitation. Can we start the slides?
Before proceeding with the case presentations, kindly note that questions will be answered at the end of each case scenario. Please add the questions in the chat box. Our senior estimates, Dr. Manohara and Dr. Patnaki, will coordinate this.
Now we have the first case presentation on Addl CNH. Stage 1 being low risk. A 45-year-old female, pre-menopause age with no known comorbidities presented with abnormal pregnancy for 3 months. Endometrial sampling and biopsy was done and diagnosed to have endometrial carcinoma, endometrial type, FIGO grade 1. MRI pelvis, abdominal pelvis showed 2.6 and 1.7 due to hyperintense lesion, noted partially filling and distinct canal with no parametrium or no excessive fluctuation. Patient showed mild endometrial enhancement, most relevant pelvic lesion. She was diagnosed to have C endometrium FIGO stage 1 grade 1. She underwent laparoscopic robotic assisted total hysterectomy and bilateral salvage with bilateral pelvic sampling made of biopsy. Most of HP endometrial adenocarcinoma is primary mutation, FIGO grade 1. Bilateral infusion not identified. Uterine serosal involvement was not identified. No uterine segment involvement not identified. Cervical stroma involvement was not there. No intravascular infusion. No other piece of or involvement was clear. Bilateral pelvic segment with no biopsy done. No node involvement. Molecular testing was done for this patient. IHC for enema protein was done. MLH1, MSH2, MSH6, AMS2 showed intact nuclear expression. And it was indicated as enema intact with no loss of nuclear expression of enema proteins. Stage pathology stage B1A, B0, no myocardial infarction, MPs and negative, low risk. Plan of management, complication for the patient. As for low risk, carcinoma endometrial, what we recommend is total abdomen no infection, no RT, or vaginal vaginal recurrence rate is 25%.
I would agree with the line of management. I was just wondering why just MMR was done. Why was P53 not done? I was just wondering, MMR was done, why was P53 not done?
Because it was low risk, so we get the MMR to rule out the means. It was a young lady, and because it was low risk, we didn't go ahead with
Okay. In any case, if P53 was mutant, in any case of P53, she is still qualifies to be a low risk, and no adjuvant treatment was required. Now, one of the questions you asked earlier was whether, one of the questions that you asked was, is DNC required for low risk? Now, age is one of the strongest prognostic factors for postmenopausal bleeding. So, fractional dilatation curettage has been the traditional definitive diagnostic procedure. However, what we do here is a routine office endometrial biopsy procedure, pipple biopsy, which is accurate to the tune of 90%. However, pipple biopsy is inferior in predicting the final post-hysterectomy tumor grade. Now, if pipple biopsy turns out to be negative in symptomatic patients in whom adequate tissue is not obtained, and in patients with persistent postmenopausal bleeding, then probably you would consider DNC. Pap smear is never a diagnostic test for endometrial cancer because it is only 30% accurate, and the cells are not removed directly from the lesion. Now, hysteroscopy was one of the questions in a subsequent slide. Hysteroscopy enables one to directly see the lesion, establish the extent of disease, identify other competing diagnoses, and perform a biopsy. And positive hysteroscopy result is associated with a 72% probability of carcinoma endometrium. And there is a high negative predictive value of 0.6%. Accuracy of hysteroscopy is higher in postmenopausal women. Ultrasound is a technique to identify the endometrial thickness. There are no cancers. One can say that there's probably no cancer if the endometrial thickness is less than 8 millimeters. And if 5 millimeter cutoff is used, the sensitivity is 100% and specificity of 96%. So, in managing a patient with carcinoma of the endometrium, you would use an ultrasound to measure the endometrial thickness, CT to assess for lung mets and abdominal paraortic or paraortic node mets, MRI to assess the endometrial and cervical involvement. The endometrial cancer is typically mildly hyperintense on T2A images compared to the norm. So one should evaluate the uterus in at least 2 planes using T2A images. An ideal approach would be a multi-parametric approach combining T2-weighted image, diffusion-weighted images, and gadolinium contrast. This is probably the most comprehensive approach to assess local tumor spread. Now, cervical invasion is assumed when there is thinning or focal disruption of the hypointense signal of the cervical stroma in continuity with the tumor. Now, next slide. Now I'll talk about just the surgery first. Lymphadenectomy I'll talk about later. Surgery involves thorough inspection of the endometrium, inspection of the peritoneal cavity, collection of cytological washings, sentinel lymph node dissection, and hysterectomy. Hysterectomy can be extrafacial, can be robotic, laparoscopic, or abdominal. Unlike carcinoma of the cervix, where laparoscopic hysterectomy has shown inferior survival. And one of the questions asked was about the vaginal cuff. Removal of the upper cuff, upper vagina does not decrease fault recurrences. So unless vagina is not unless the vagina is involved, one does not have to remove the cuff of vagina. Omental biopsy and staging omentectomy is carried out in patients with gross spread to the omentum or admixture, or in high-risk histologies like serous and clear cell. Now, 5% of endometrial cancers have metastatic disease to the ovaries or fallopian tube, and so admixture have to be removed. Our caveat here is it is not recommended for patients with genetic risk for ovarian cancer, such as germline BRCA mutations or Lynch syndrome. And preservation of ovaries can be considered in premenopausal women with figure stage 1, grade 1 endometrial cancers. And staging of mastectomy should be considered in patients with carcinosarcoma and serous type endometrial cancer. And for stage 3 and 4, the aim of surgical treatment is cytoreductive surgery, just as in the case of carcinoma. So, in summary, in early stage endometrial cancer, the aim of surgery is to remove macroscopic tumor, examine for microscopic metastasis, and stage the tumor to assess the need for adjuvant therapy. And for stage 3 and stage 4, it is cytoreductive surgery with the aim of complete resection. One of the questions was about PET. Now, recently the RCR has published their latest update, 2022 update for guidelines in PET. And PET is advised only if there is a suspected recurrence of endometrial cancer when other imaging is equivocal. It can also be used for staging of high-risk endometrial cancer with equivocal findings on conventional work. Now, would you consider the newer molecular staging, molecular profiling in all patients with endometrial cancer? The answer to that would be yes. Now, ESMO recommends all patients should have reported histological type, figure grade, biometric invasion, and NBSI, poly hotspot analysis, MMR protein IHC, and IHC staining for P53. However, we would find it difficult to do poly testing because it requires NGS. So what we follow is what is done by the British Association of Gynecological Pathologists. Now, first do a biopsy, then you do MMR, P53, ERPR, IHCs are all cancers. And if they are MMR abnormal or P53 abnormal, adjuvant treatment is given. We don't, as a routine, do poly testing. And surgical staging we'll get the final histopathological type, final grade, final phenopathological stage, and the presence or absence of substantial NBSI. Focal NBSI does not change the adjuvant treatment. Substantial NBSI is an indication for post-op EBR.
51-year-old postmenopausal lady. Center with abnormal ultrasound indicated antibiotic lupus with heterogeneous and peripheral endometrial. Endometrial sampling and biopsy was done and diagnosed to have endometrial adenocarcinoma grade 1. MRI abdomen and pelvis showed an indefined heterogeneous hypometric solution in the endometrial cavity, showing diffusion restriction and more than 50% myometrial invasion. She was diagnosed to have carcinoma endometrial for stage 1B, P1B N0 grade 1. She underwent total abdominal hysterectomy plus bilateral salpingo-oophorectomy, rectorectomy, bilateral lymph node resection. The post-op histopathological examination showed endometrial adenocarcinoma with grade 1, myometrial invasion more than 50%, uterine cirrhosis involvement, lower uterine segment involvement, cervical stoma involvement is not seen, lymphovascular invasion is not seen, all margins are clean. Furo-operative red lymph node sonography are free of tumor. Final histopathological diagnosis endometrial adenocarcinoma, P1B N0 NS. Age, grade, and plan of management. The historical endometrial adenocarcinoma grade 1. Stage P1B N0 NS with lymphovascular phase invasion negative. So the patient belongs to intermediate risk category and surgical staging is performed. The cardiac management in this case would be, since the age is less than 60 years and the risk is intermediate, the patient has lower risk of relapse, hence the patient can be kept under observation and no adjuvant treatment is advised as per ISRO guidelines for endometrial cancer.
Even the ESMO guidelines advise the same thing. Patient can be kept under observation and no adjuvant treatment is advised. Is lymph node dissection advised in this patient? MR sequences we have already discussed. And at what stage should we consider evaluation for metastasis?
As the depth of tumor invasion increases or tumor grade increases, the frequency of pelvic and parotid nodal mets also increases. The highest risk group therefore includes the patients with grade 3 tumors and outer third invasion and who had pelvic node involvement in 34% of cases and 23% para-aortic node involvement. And if, for example, you get a patient who has not undergone pelvic node dissection, one may grossly estimate the probability of nodal involvement based on these data to select for or against the use of adjuvant therapy. So we usually probably do not require adjuvant treatment in patients with grade 1 or those who have endometrium only involvement. Now, lymphadenectomy provides best estimate of disease, of the spread of disease, prognosis, and treatment decision. The upper limit of lymphadenectomy is conveniently taken at the inferior mesenteric artery or at the level of renal vessel. However, pelvic and or para-aortic node dissection is associated with nerve-vascular injury, lymph cyst formation, lymphedema, and neuralgia. There have been 2 large randomized trials which have looked at the effect of role of lymphadenectomy in CA endometrium, and they've been negative in the sense that none of these trials have shown a benefit for lymphadenectomy. The ASIC trial had 1,408 patients randomly assigned to TH plus VSO plus or minus pelvic lymphadenectomy. The median follow-up was 37 months. There was no difference in survival. The drawback of the ASIC trial was it was an intent to treat study, but had a relatively large party, not taking into consideration the surgical findings. The second study, the Penici trial, had around 500 patients randomized to systematic pelvic lymph node dissection or not. And the drawback of the Penici trial was the lymphadenectomy was limited to the pelvis. Para-aortic lymphadenectomy was the operative therapy was to the discretion of the physician. Adjuvant therapy was similar in both groups. Now, the only trial which has shown a benefit was the Japanese CEPAL trial, that is surgical evaluation of para-aortic lymph node. However, this trial was retrospective, and those were 671 patients and demonstrated a reduced risk of death hazard ratio of 0.44%. So, depending upon the grade, myometrial invasion, and histology, lymph node evaluation could be omitted in endometrial figure 1A, grade 1, grade 2 disease, since the risk of nodal metastasis is very low. Again, to summarize, lymphadenectomy has not shown a benefit in terms of survival, but it has prognosticate and decide on therapy. Sentinel node biopsy has emerged as an alternative to lymph node dissection for lymph node staging. The sensitivity of sentinel node staging approach has been endorsed by multiple studies favoring its implementation in surgical management. And it has become the standard of care in endometrioid adenocarcinoma. Studies are still ongoing in non-endometrioid cancers. Now, the landmark study was a FIRE study, which had 385 patients. The successful mapping was defined by observed channel leading directly from the cervix directly into, or at least one candidate node. Sentinels were identified in 86% of the patients. Now, if you inject the dye directly into the fundus, you can go directly to the para-aortic node, and two out of 3 patients with a mapped isolated para-aortic node had metastatic disease. 97.2% sensitivity and nearly 100% negative predictive value. Now, success depends upon the completion of site-specific comprehensive node dissection if mapping fails, and you should remove any suspicious nodes irrespective of mapping. Now, isolated tumor cells on ultrasonic, if isolated tumor cells are identified, which are less than 0.2 millimeters, on pathological node evaluation, adjuvant therapy does not impact oncological outcomes.
Thank you, sir. Now we move on to the next presenter on intermediate risk endometrium.
Facing a 61-year-old female, P3LP, presently with complaints of postmenopausal bleeding for 2 months. She was evaluated outside and MRI photos was taken and showed nitrous express P2 hyperintense lesion, focal diameter extension of less than 50%, no extension to cervix parameter, no excessive extension. Significant infertility. Endometrial biopsy and 22 outside showed endometrial carcinoma grade 1. And she was diagnosed with C endometrial stage 1A grade 1. She underwent total reconnaissance bilateral saphenous hysterectomy on March 20. She was diagnosed with C endometrial stage 1A grade 1. She underwent total abdominal hysterectomy bilateral saphenous hysterectomy on March 2020. Post of histopathological examination, the tumor size was 7 + 3 + 2 cm. Endometrial carcinoma grade 1. Myometrial invasion was more than 50%. Uterine sinusoid cervical stromal invasion was not there. LVSA negative, endometrial thickness was 16 mm. Risk stratification, grade 1 endometrial adenocarcinoma, because stage 1B, low grade, LVSA negative, so it will come under intermediate risk. So the plan of management is surgery and vaginal brachytherapy 7 days 3 sessions.
Thank you, Dr. Mohan. So the query for this patient was, in this case, lymphadenectomy was not done. So what would be the role of SLNB in this patient for stage 1B disease?
Standard of care would be central lymph node biopsy in all patients, regardless of grade, maybe not. If you're doing a surgical lymphadenectomy, maybe not. For the, as I showed you, the Kreisman data for early stage disease, if the chance of lymph node involvement is less than 5%, you would not have to do a lymphadenectomy. But central lymph node biopsy is carried out in all patients.
Should we consider SLNB in all low-risk cases? If you're not expecting lymph node involvement, given low grade or low myometrial involvement?
You're asking whether central lymph node biopsy should be carried out in
low-risk cases, sir.
Yes, in all patients. Central lymph node biopsy would be carried out in all patients. If you're doing a surgical lymphadenectomy, that need not be done.
Thank you, sir. Now we will move on to the next case presentation on stage 1B, high intermediate. Good evening. I will be continuing with the high intermediate stage 1B. 38-year-old P1L1 premenopausal female with no comorbidities, belongs to class 1 obesity as per CDC, presented with abnormal uterine bleeding for 6 months. Transvaginal ultrasound was done. It showed markedly thickened and heterogeneous endometrium with ill-defined anterior border and no clear separation from myometrium. Endometrial sampling and biopsy was done and diagnosed of endometrial adenocarcinoma, endometriatic, grade 3. MRI abdomen pelvis showed 9.7 cross 1.6 cross 4.4 centimeter T2 hyperintense lesion, completely filling and distancing the endometrial canal. Focal myometrial extension less than 50% for a length of 6 mm along the anterior uterine wall, with no extension to cervix, parametrial, and no extraserosal extension. Lesion showed mild heterogeneous enhancement and no significant pelvic lymphadenopathy. Diagnosis of C endometrium, FIBO, stage 1A, grade 3. She underwent total abdominal hysterectomy but with bilateral salpingoophorectomy with retroperitoneal and bilateral pelvic lymph node dissection. Postoperative histopathology showed endometrial carcinoma, grade 3, and myometrial invasion was present. Depth of invasion more than 50%. Lower uterine segment was involved with tumor, and there is no LPSI and no peritoneal invasion. No ascitic fluid is not submitted, and all margins are free, and all 26 lymph nodes were free. And in this case, with molecular markers, that is MLH1, MSH2, MSH6, MLH1, PMS2 showed intact nuclear expression and no loss of MMR proteins. Tumor is slightly MSS and MSA low, that is low probability of MSAH, and it is MMR proficient and is slightly microsatellite stable. Further P53 testing was not done, and CT and B1 were not done. And in this, it is suggestive of high grade pathological T1B N0MS, ABSA is negative, and risk category is high intermediate risk, and surgical staging was performed in this case, and molecular markers known, but it is incomplete. Plan of management: vaginal brachytherapy, high intermediate risk, and adjuvant chemotherapy can be considered in this case of high grade based on protected trial. But the question remains whether benefit outweighs the toxicity for stage 1 to stage 2 endometrial carcinomas, and multidisciplinary shared decision making is needed. If CTNNB1 mutant is there, that is considered under that is coming under intermediate risk, and CTNNB1 wild type, which suggests a favorable type. And if P53 mutant, that is endometrial carcinoma, P53 is coming under high risk, and P53 if it's wild, that is endometrial carcinoma, that is no specific type, no specific molecular pathology, intermediate risk. And
thank you for the presentation, sir. Actually, for this case, the query was, what would be the role of chemotherapy in this patient?
Okay, this was 1B 1B grade 3 disease. I would have just given vaginal brachytherapy. So the PORTEC analysis, the PORTEC 3 analysis, the updated analysis was published recently with a median follow-up of around 72 months, and showed 5% overall survival benefit and 7% freedom from failure-free survival benefit in serous carcinoma or with stage 3 disease. Though the ESMO guidelines suggest that addition of chemo resulted, it's true that addition of chemo results in significantly higher treatment-related toxicity, but the most differences were solved from 12 months onward, with persisting difference in long-term sensory neuropathy. So it's shown survival benefit only for stage 3 disease and for serous carcinoma. Now, why I asked about P53 mutant is that patients with P53 abnormal endometrial cancer have therapy as well, chemotherapy and RT, with absolute difference in survival as well as relapse-free survival. For chemotherapy alone in these patients, now GOG 258 would suggest yes, because there was no difference in with chemotherapy or chemotherapy plus radiotherapy. However, if you look at the, can I have the next slide? Okay, this is the GOG 258 trial. The combination of chemotherapy plus radiation did not provide a benefit over chemotherapy alone with respect to relapse-free survival in patients with stage 3 or stage 4 disease. However, if you look at the vaginal recurrence and the pelvic and para-aortic node recurrence, it was the cumulative incidence of pelvic or para-aortic node recurrence was 11% in the chemoradiotherapy group compared to 20% in the chemotherapy only arm, and the vaginal recurrence was also high. So for stage 3 and for stage 4 disease, you would tend to combine chemotherapy and radiotherapy. But for your particular patient, she's only stage 1, grade 3 disease. If she has undergone a proper pelvic lymph node dissection, I would probably be happy with this vaginal brachytherapy and not give chemo. If she was MMR deficient, they've taken out women with from the POTEC 3. Leon Castello et al. Has taken out the women with MMR deficient cancers, and they showed improvement in 5-year lapse-free survival with chemotherapy combined therapy alone. So if she was MMR deficient, a non-specific therapy, and there's no benefit from chemotherapy combined with radiotherapy. Okay, if this patient was MMR deficient, then there is relapse-free survival benefits in terms of chemoradiotherapy, but that is only for stage 3 and stage 4 patients. And if this patient was non-specific mutational profile NSMNT, there is benefit only for radiotherapy and not for chemotherapy and radiotherapy. So it is essential in nowadays to at least do an MMR and p53 immunohistochemistry for all your patients. Now, polymute is a different story altogether. Polymute patients do extremely well, and polymute is an indicator of a favorable endometrial cancer prognosis, independent of other clinical pathological variables. Hence, it's been recommended that patients with stage 1 or 2 tumors and polymute can now be considered to be low risk and unlikely to benefit from adjuvant treatment. However, it must be remembered that patients with polymute in the POTEC 3 trial were patients, and it is surgery. So what we do is, if we don't do polymute, and if other factors are there, such as grade of the disease and stage of the disease, we would treat according to the next. So, in summary, extensive study of these surrogate markers have shown that there is a good relationship to clinical outcome, and the prognostic value is the polymute. They do extremely well, almost 100% survival, while the p53 is the one at the bottom. They do extremely bad, and the ones in between are the MMRD and the NSMNT. And there's no statistically, you might ask if the patient has got something other than a serous cancer, will p53 IHC benefit? Now, that has also been shown in this trial. There was no statistically significant difference in clinical outcomes between patients with p53 abnormal serous and p53 abnormal endometrial cancer with other histology. Should need treatment, you can de-escalate adjuvant treatment.
A 65-year-old female presented with complaints of postmenopausal bleeding for 2 months. CECT shows irregular heterogeneously enhancing soft tissue density lesion noted in the uterus, centered in the endometrium, measuring 2.5 cross 3.3 cross 5.2 centimeter. Inferiorly, the lesion extends to the endocervical canal. No extrauterine extension of the lesion is noted. Endometrial biopsy shows endometrial carcinoma grade 1. She was diagnosed to have carcinoma of the endometrium, before stage 2 and grade 1. She underwent total abdominal hysterectomy with bilateral salpingo-oophorectomy in October 2022. Post-op tumor size of 8 cross 4 cross 3.2 centimeters in endometrium. Histological type endometrial carcinoma and not otherwise specified. Grade 1 myometrial invasion present more than 50%. Uterine serosal involvement not defined. Lower uterine segment involvement is present. Cervical stroma involvement is present. Other tissue or organ involvement in the left tube is positive. LBSA not identified. Margins, right and left parametrial shave margins, anterior and posterior vaginal cuff margins are free of tumor. Pathological stage is before stage 2. Summary of the case: it is a grade 1 endometrial adenocarcinoma. Pigo stage 2, low grade, LBSA negative, cervical stromal invasion is positive. It comes under high intermediate risk. The plan provisionally is adjuvant EPRT followed by brachytherapy boost.
The queries would be role of lymph node dissection in stage 2 endometrial carcinoma.
Again, I've talked about this before. Two patients should undergo a lymph node dissection if you don't have the facility for central lymph node biopsy. If you have the facility for central lymph node, all patients should undergo a central lymph node biopsy.
Good evening, sir. I will
Go ahead.
I will be presenting stage 1B clear cell carcinoma. 55 years old, nulliparous female, post-menopausal lady, presented with complaints of white discharge per vagina for past 2 months. Ultrasound abdomen and pelvis showed antevated uterus with endometrial cavity occupied with well-delineated hypoechoic mass of size 8.2 cross 6.8 centimeters with extensive neovascularity. Transvaginal sonography showed uterus of size 8.4 cross 6.5 centimeters with thickened endometrium of size 6 cross 3.8 centimeters. Endometrial biopsy was done and it showed clear cell carcinoma. CT thorax abdomen pelvis of this patient showed bulky uterus and endometrial cavities distended with an ill-defined enhancing soft tissue density lesion of size 8.3 cross 10.7 cross 7.2 centimeters. Diffuse myometrial thinning and maximum thickness is 5 mm. MRI abdomen and pelvis showed an ill-defined T2 heterogeneous hyperintense lesion in the endometrial cavity showing diffusion restriction and more than 50% myometrial invasion. She diagnosed to be a case of carcinoma endometrium, FIGO stage 1B, clear cell carcinoma. She underwent total abdominal hysterectomy with bilateral salpingo-oophorectomy with retroperitoneal and bilateral pelvic lymph node dissection. Post-op histopathology showed a clear cell carcinoma, FIGO stage 1B with myometrial invasion more than 50%. Uterine serosal involvement not identified and lower uterine segment involvement present. Cervical stromal involvement not identified. Bilateral fallopian tubes and bilateral ovaries are free of tumor. Peritoneal ascitic fluid status unknown and lymphovascular invasion is not identified. Margins, ectocervical margin is free of tumor. Parametrial margins are free of tumor. Then lymph nodes, total number of lymph nodes submitted were 31 and no lymph node involvement. Pathological staging P T1B N0 MS. Histology is clear cell carcinoma and pathological stage P T1B N0 MS. LBSI not identified. It comes under high risk and surgical staging was performed for this case. The provisional plan of management will be adjuvant external beam radiation 48.6 grade at 1.8 grade per fraction with concurrent cisplatin 50 mg per meter square first week and fourth week of EBRT followed by walled brachytherapy 6 grade into 2 sessions. It will be followed by the adjuvant chemotherapy of paclitaxel 170 mg per meter square and carboplatin AUC5 3 weekly for 4 cycles.
Okay. Am I audible now?
Yes, sir.
Now you said you must always remember that the FIGO staging is a post-op staging. So in one of your slides, you said this lady had a FIGO stage 1B prior to surgery. The FIGO staging is always post-op. There is a pre-op FIGO staging, but that depends on the length of the uterus that is found in. Now, I would have agreed with this line of management maybe about 6 months back. Now, this is the recent ESMO guidelines from Ocknin et al. Now, can you go through this? And this particular lady does not qualify as high risk. Clear cell carcinoma, the endometrium, has not been mentioned anywhere in this risk grouping. Now, earlier serous and clear cell carcinomas were grouped together and as having a similar bad prognosis. But in the post hoc analysis of the histogram on the side, across the different cancers, however,
Now, if you, about 6 months back, maybe I would have agreed with you with this particular line of management. But this is the recent ESMO guidelines from Oakland et al. Now, just go through the table. You won't see clear cell carcinoma anywhere, not in the high risk, nowhere. Now, that is because earlier serous and clear cell cancers were grouped together and were described as having a similar prognosis. However, in the post hoc analysis of PROTECT 3, it was shown that the greatest risk of recurrence was for serous cancers, but the clear cell cancers behave very similar to the endometrioid cancers grade 3. So in that trial, in the PROTECT 3 trial, chemo RT showed a survival benefit only for serous and stage 3 cancers. And in the most recent risk grouping, which incorporates molecular profiling, clear cell carcinomas have not been included in the high risk group. So they can be treated just like grade 3 endometrioid cancers. Having said that, approximately 50% of all clear cell cancers are p53 mutant. So in which case, if they are p53 mutant, they would be treated just like they will be treated based on the molecular profile. So this patient has stage 2, is it? Was she stage 2? She has a 1B grade 3 disease. So she'll be treated with just vaginal brachytherapy and not chemo. She'll be treated just like an endometrioid cancer grade 3. Can I have the next slide? Now, if it is a patient with a stage 3 cancer, that would be different. Okay, you can go on to the case scenario.
So, case of C endometrium, 3C2, 66-year-old postmenopausal female with the comorbidity of diabetic hypertension and obesity, presented with complex of postmenopausal transvaginal ultrasound shows thickened endometrium and with smooth contour.
Go on.
Transvaginal ultrasound considered because of irregular endometrium, she was considered for hysteroscopy, dilation, and fluid. Hysteroscopy appearance of the endometrium consists of multiple polypoid areas. And the patient was suspected of having hyperplasia of endometrial cancer, so direct biopsy was done. And the pathology report revealed as endometrial adenocarcinoma clear cell type. So she was taken up for pelvic MRI and the CT thorax abdomen was done. Pelvic MRI showed the endometrial involvement with more than 50% biometric invasion, and disease was extending into the cervical stroma, and multiple pelvic and parotid nodes were there. No other distance product disease was found. So the patient underwent total abdominal hysterectomy with bilateral salpingolectomy, along with the pelvic and parotid lymphadenectomy and the lymphadenectomy. So the post of histopathology report revealed the clear cell carcinoma grade 3 because stage was 3C2. All the margins were free of tumor. Cervical stromal involvement was present. Total of 24 lymph nodes, 19 were positive. Biometric invasion was more than 50%. Right and left parametric margins are free of tumor. The peritoneal ascitic fluid status was unknown. LBSA was substantial. So it is a bigger stage 3C2. Histology wise, it is a variant grade 3. LBSA present and it was substantial. Biometric more than 50% identified. Molecular subtyping was not performed, and the risk strata comes under high risk group. So the plan of management was adjuvant ABRT 48 hours period with cisplatin of 50 mg per meter square on week 1 and 4, followed by adjuvant 60 to fraction, followed by 4 cycles of carboplatin and paclitaxel 175 mg per meter square. So
The query from our side is, should we follow the same treatment guidelines for clear cell histology in high risk strata similar to serous and stage 3, and what would be the evidence?
The evidence is what I showed in the previous slide. Now, clear cell carcinomas, the post hoc analysis of PROTECT 3 suggested that clear cell carcinomas can be treated just like just like endometrioid adenocarcinomas grade 3, and they are no longer included in the high risk category. So this patient has stage 3 disease. I would give adjuvant chemotherapy for 4 cycles paclitaxel followed by extended field radiotherapy.
it's a 35-year-old female presented with normal uterine bleeding. She was evaluated and an ultrasound done was suggestive of cervical fibrosis. Patient was taken up for myometry, but intra-op they were able to see findings suspicious for malignancy. So a cross-section was sent, which turned out to be adenocarcinoma, endometrioid. So the surgeons went in for TH with BSO with right pelvic lymph node dissection. But intra bilateral pelvic and parietic nodes were palpable, but just the right pelvic nodes were sampled. There is a query here whether the surgeon should have removed all the lymph nodes. So post of histopathology was endometrial adenocarcinoma, low grade, with myometrial invasion more than 50%. Lower uterine segment was involved, cervical stromal involvement was present. All margins were free, and all the 4 lymph nodes which were dissected were positive. So it is a low grade E3C N1A with LVSA substantial high risk, and all lymph nodes were not removed. So the plan of management would be based on PROTECT 3, adjuvant chemoradiation, followed by vaginal brachy fulgurate interview, followed by adjuvant chemotherapy, partly 3.
What about the paraortic nodes?
Parametric nodes are not.
The paraortic nodes were enlarged and palpable, but
Cancer intra parietic nodes were palpable and pelvic nodes were also palpable and enlarged, but only sampling of right pelvic nodes were done.
ideally those nodes should have also have been removed. All the enlarged nodes should have been removed. But because those have not been removed at CT scan, if these nodes are enlarged, I would treat with extended field radiotherapy and give a boost to the paraortic nodes as well. There is no advantage to doing a lymph node dissection, but the enlarged node should have been removed. When would we increase the superior border in EBRT portals? Now, in this situation, you would include the paraortic nodes as well. The lower border would be the usual lower border.
And does the EBRT portals change in case of substantial?
No, they remain the same. Only thing is substantial LVSI is an indication for EBRT. So you should give EBRT.
Is there any role of second surgery?
Ideally, yes, you remove these nodes. But if it is not possible, then you go ahead and give extended field radiotherapy and boost the enlarged paraortic nodes to at least 55 to 60 grade. In case paraortic field is how much higher. Now in cervix, you tend to keep the upper border of the paraortic fields below the renal artery. In case of endometrium, you extend at least 1.5 to 2 centimeters above the paraortic, above the renal.
Indication for paraortic
If there are paraortic nodes involved on your CTSM or on imaging, there is also guidelines which say that if there is more than one common lymph node positive, you should include the paraortic nodes. Or if there are multiple pelvic nodes positive, you should include the paraortic nodes. But we've not, I have not really put that into practice. Just go one level above. That is what we do at present. Just a point about sequencing chemotherapy and radiotherapy. We usually, what we do here is we give chemo first, followed by radiotherapy. If you give radiotherapy first, then it's going to be difficult to give chemotherapy afterwards, because most of the bone marrow is in the pelvis. 40% of the red marrow is in the pelvis, so it's going to be difficult to give chemo afterwards. So what we give is chemo first and followed by radiotherapy. And there is also some retrospective data from the National Cancer Database to say that there is some survival benefit if you give chemo first followed by radiotherapy rather than RT first. In the POTEC 3, in fact, RT first was given first followed by chemo. But there is some retrospective evidence to say that the reverse would be more.
About a 77-year-old postmenopausal woman presented with widest discharge of vagina and significant loss of weight. She was evaluated and endometrial sampling was done. Epithelial cell abnormality was present, positive for malignancy. She was evaluated with MRI abdomen and pelvis, which showed uterus retroverted and measures about 18 into 45 into 40 mm. Large, ill-defined proliferative growth of size 42 into 38 mm was noted in the endometrial cavity. Endometrium appeared grossly thickened and measured 22 mm thickness. Endometrial differentiation was lost, that is, myometrial invasion was present. Infiltration up to outer myometrium, moderate fluid collection seen in the uterine cavity, and parametrium appeared normal. No extrafacial infiltration was seen. Cervix and vagina appeared normal. Multiple enlarged bilateral internal iliac lymph nodes was seen, the largest one in the right side, measuring 18 into 14 mm. Diagnosed to have carcinoma endometrium Figo stage 3C1. She underwent TH plus DSO with a retroperitoneal and bilateral pelvic lymph node dissection. In post of histopathology, serous carcinoma endometrium grade 3 high grade was noted. Myometrial invasion was present and depth of invasion was more than 50%. Lower uterine segment was involved by the tumor. Cervical stromal involvement was not identified, and LVSI was identified. Ascitic fluid not submitted. Margins 2 millimeter from the left parameter resected margin was seen. 1 out of 25 lymph nodes were involved. That is mainly of para-aortic lymph node. 1 out of 4 was dissected. Distal length was not applicable. The grade of the tumor was high grade, pathological stage PT3B N2A MX, and the stage PC2 was identified. LVSI was present, histology serous carcinoma, high risk, but surgical staging was not performed. Plan of management will be adjuvant EBRT 48.6 per 20 by 25 fraction with concurrent cisplatin 50 mg per meter square. Week 1 and 4 followed by 4 cycles of carboplatin and paclitaxel.
So regarding the last case, would you agree with the management? Are there any differences in the high-grade serous carcinoma?
High-grade serous carcinoma, chemotherapy, 4 cycles paclitaxel, followed by adjuvant EBRT. Was the cervix involved? There was stromal involvement, right? This patient had cervical stroma was not involved. So that be it. 4 courses of paclitaxel carboplatin followed by radiotherapy. Pelvic radiotherapy, extended field radiotherapy. 45 gray in 25 fractions.
Sir, if it is a grade 3 and LPSI, should be considered for grade 2 in this case?
To me, the only indication cervical stromal involvement or positive margins. Otherwise, there is no indication for vaginal brachytherapy. EBRT, yes, EBRT followed by vaginal brachytherapy only in patients with cervical stromal involvement or margin positive.
A 66-year-old postmenopausal female with bleeding fever. She was a known case of rheumatic heart disease and mitral stenosis in symptomatic for breathlessness. She was evaluated in the OG department and was diagnosed with endometrial adenocarcinoma, grade 1. MRA taken should have gone to 2.9 to 4.8 centimeter lesion. There is involving the outer 50% of myometrium. There is no obvious extracellular extension. The lesion wasn't involving cervix with no parametrial invasion and no significant lymphadenopathy. She was certified as intermediate risk and planned for total abdominal hysterectomy with bilateral saphenopectomy, but in view of high risk of perioperative complications or mortality, clearance for anesthesia could not be obtained, and the plan was changed to radical EBRT and brachytherapy. EBRT goes to 65 gray with the TCRT or IMRT technique, and brachytherapy are not feasible due to comorbid condition. The target is aiming to be achieved with radical treatment. We treated at least 65 gray. 90% of the city volume. And the dose of 80 gray.
So this will be the query. What would be the field order? EBRT plant
field orders are not different. If there is myometrial involvement, patient should undergo radical EBRT plus brachytherapy. If myometrium is not involved, or if the superficial myometrium is involved, patient can undergo brachytherapy alone, especially for grade 1 or 2 tumors. The CT would include the entire uterus, cervix, and these patients do badly. In my experience, these patients almost always recur. Not as good as surgery followed by post-op EBRT. Now, if there is myometrial involvement, these patients should undergo radical EBRT plus brachytherapy. If there is just superficial myometrial involvement, especially for grade 1, grade 2 disease, patients can undergo brachytherapy alone. The uterine CTV would include the entire uterus and the proximal vagina. And if MRI is available, you should make sure that the GTV is encompassed by the CTV. The nodal CTV is as for any other patient. Dose should be 45 gray with at least 55 gray to the gross nodal disease. And that should be followed by brachytherapy, 7 gray to 0.8 with body loading. Body loading means you don't need an inverted olive as in the case of cervix. You should be loaded from the top. I hope you get what I'm trying to say. And the EQD2 should be at least 48 gray for brachytherapy alone, or if there's a combination of EBRT plus brachy, 65 gray to the D90. The lymph nodes involved should be as for any other patient.
Thank you, sir. When would we treat paralytic in these patients, sir? If there was no gross node in the paralytic?
There is no gross nodal involvement, we wouldn't treat the paralytic nodes.
We want to just a brief overview on brachytherapy in endometrium. For ABS, recommends the proximal 3 to 5 centimeter vagina be treated, and for certain other histologies, it recommends treatment of the entire vagina cannot be considered. Coated 4A, which mainly does not include iris, actually reduces the volume to only upper 1/3, and length they give us approximately only 3.5 centimeters. They recommend delineation of the CTP at a 3 mm margin, but they advise to keep the reference points at around 5 mm depth. And when we are planning brachytherapy, usually in our center, we generally keep points at 5 mm from the vaginal mucosal surface. But when we also try to deliver up those at the apex or along the sides near the top of the wall. So when we try to pull the dose by manual optimization, it leads to the Indian club pattern as well. So what would be other optimization strategies in these cases? And what would be the optimum length of vagina to be treated in this scenario? Should we treat apex and upper 1/3? Or
Now, earlier when I started out, we were for high-grade endometrioid carcinomas and for serous carcinomas, we should be treating the entire vagina. Now, the entire vagina, length of vagina is not treated anymore because of the increased risk of stenosis and lower rates of vaginal recurrences. Having said that, there is no consensus regarding the optimal fractionation schedule, treatment length, depth of dose specification. If 3 millimeters from the vaginal mucosa, so if Monotech 2 trial, 7 grade for 3 fractions to 0.5 centimeters depth to proximal 3 to 5 centimeters or half a vagina as was specified in Monotech 2. Single vaginal cylinder is most often used. CD-based planning is not commonly done. However, it would help assess air gaps between the applicator and the vaginal gaps. And the optimization plans for a domed applicator is usually placed around the apex and lateral aspects of the applicator at the surface and not at 0.5 centimeters.
now, regarding radical brachytherapy for say endometrial, generally it is complicated with the large OAR doses as well. So, what strategies we can use to optimize and reduce OAR doses? And what would be the vagina this we had discussed at the upper half?
Radical therapy, you aim for an EQD to a 48 gray, that is 6 gray in 6 fractions. Recommended dose fraction of brachytherapy, that is strategies of BE2E, bladder filling, rectal NT, length of vagina treated in inoperable tumor treated radically by brachytherapy. You treat, as in the other situations, you would treat the upper 1/3 to half of vagina. Recommended dose fraction, aim for an EQD to a 48 gray, 6 fractions, bladder filling, rectum inting would be to achieve the target and to reduce OIR doses. It has been shown that bladder filling will decrease the bowel dose and the bladder dose without affecting dose to the bladder, rectum, or colon.
Would you like to give any last comments for us?
Nothing much, really. Except maybe molecular profiling should become the pathological parameters. So,
thank you, sir. Thank you for taking a time to have a lecture on with us on endometrial. Thank you for answering all our queries, sir. This was a very illuminating session for all of us, and we have all gained new knowledge to go along with it. Thank you, sir. I say it again. Thank you for taking the time to instruct us.
Thank you very much. Thank you.